technician at the Uganda Ministry of Health, and she'll be discussing the impact of implementing test and treat policy on pediatric ART enrollment and coverage in Uganda.
Thank you very much. I would like to thank the organizers of the conference for giving us an opportunity to share the test and treat approach for all HIV-infected children under 15 years in Uganda. And having listened to the findings of the START study, I'm glad we took this approach as a country. Following the WHO guidelines in 2013, we adopted the test and treat policy for all HIV-infected children under 15 years. And we launched and disseminated the guidelines to all stakeholders through 3-day health facility-based trainings. And these were associated with mentoring during the same period, during January to December 2014. So we would have CMEs in the morning, we would have sessions in the morning and in the afternoon, but in between there, we're working with the health workers, coaching them, and working with them to initiate children who are in priority on treatment. So when we looked at our data, in comparison to the 2013 WHO guidelines, we found out that 83% of all the children would still be eligible for ART, and this included all the under 5s, but also the older children who were eligible according to the guidelines at that time. And we also thought that if we remove the programmatic barriers, and this would be able to simplify pediatric ART initiation. And like I'm going to show in the next slide, we noticed that our health workers were not, a good number of them were not correctly staging children. Only 52% had correct clinical staging, and this was from our support supervision findings. And during our support supervision, we go to all the regions in the country, and this is what we found out. We also found out that access to CD4 was low. So when we looked at this, we realized that we asked ourselves what it would take to tease out the 17% who would need to be identified using CD4 and WHO clinical staging. So with that, we decided to go for the test and treat approach. And our methods were to evaluate the impact of this policy, looking at 2 different time periods, 6 months before the implementation of the policy and 6 months after the implementation of the policy. And we're mainly using our national ART quarterly reports to collect this data, and also the training reports. We developed an online training report that was being filled in during the trainings and the mentorship. So this helped us collect data at national level. We were able to monitor the progress of the training, to see who is training, how many facilities have been trained in which districts. So that is, those were our data sources. We were mainly interested in 3 outcomes for this particular study, looking at the training coverage, both the facility, the number of facilities that were being trained, but also the number of health workers that were being trained. We were also interested in looking at the ART initiation and ART coverage, again, looking at the number of facilities, but also the total number of children being initiated on treatment. And I must say here that before the rollout of these guidelines, we only had about half of the facilities providing ART as facilities that provide pediatric ART. So almost half of facilities providing ART were not providing pediatric treatment. So in our results, this slide is showing the number of health workers that were trained at the different facility level, right from the regional referral hospitals to the lowest level of the health center too. And I would like to draw attention to the last column, which has the average number of health workers trained per facility. In the training model that we decided to use for this guideline, as I've already mentioned, it was facility-based trainings. But previously we were doing workshop kind of trainings, and we were only training, like you'd be able to train 1 or 2 health workers, because some facilities have as low as 3 to 5 health workers. So we found that with this training approach, we were able to train more health workers at the facilities. And one of the things we found out, especially from the facility in charges, was that they were glad with this they were happy with this approach, because now the issue of I have never been trained, so I cannot provide care, was now being removed with this kind of training approach. So this is a breakdown of the number of health workers trained, and what we wanted to show here was the different cadres, and you can clearly see that 56% of the people that were trained were midwives and nurses. So most of our ART care is being provided by nurses and midwives. This slide shows the second outcome, the number of children newly initiated on ART, and you can see that in the red line, most of the children who are newly initiated on treatment were the older children, the 5 to 14 who had been in priority care for a long time. There was not so much change among the children who were under 2 years, because we are already implementing the test and treat approach for all children under 2 years. This was our third outcome, looking at the ART coverage, and you can see that by end of December 2013, our coverage was only at 22%. It increased to 27% in mid-2014, and by end of last year, our coverage had increased to 32%. What were our positive experiences? We have learned that removing the barriers to the eligibility criteria increases pediatric ART, and we also noticed that with this kind of approach, we are having more children initiated at the public health facilities, because it was much easier for the nurses and midwives to start these children on treatment. We also have noticed that this training approach of facility-based trainings is very successful. You are able to train more health workers, and you actually have an opportunity to train the actual implementers of HIV care in the clinics. One of the challenges that we have in our country is that sometimes when you do workshop-based trainings, they will send you theater assistants, because that theater assistant is a friend to the health facility in charge. So this training approach enabled us to train the people who provide care in the HIV clinics. And we also had an opportunity to coach them at the same time. And we've also found it to be cost-effective. Every good thing has challenges. So we had challenges with Abacaville 3TC, which was our preferred ART regimen. And this was mainly due to global supply challenges. But the good thing is that our facilities were well stocked with at least a 2 months buffer of ARVs. We also noticed a low retention at 6 months, and this was mainly for children who were 2 to 4 years. And we thought that, just like it was shared in one of the studies during this conference, that probably the mothers of these children were still trying to come up with the idea that their children have been in priority care, and now they come back for this next visit, and we are telling them, now your child has to start on treatment, despite the fact that they have a high CD4. So in conclusion, expanding the eligibility criteria increases initiation of especially the older children on ART, and interventions to improve retention are critical for long-term treatment success. I'd like to acknowledge the study participants, but in particular, the different organizations that supported us to implement this policy in Uganda. Thank you very much.